Welcome to the Brave Change Pod, where we're going to share stories and insights from global health and development. Today, we explore how lessons from Punjab, Pakistan's maternal and child health reforms could guide progress in Afghanistan. Faisal, who led the early work in Punjab, shares what he learned along the way to increasing the proportion of women giving birth in the health system by 15 percentage points. And importantly, what lessons his colleague Bahman can apply to their work in Afghanistan. It's a story of systems, people, and the courage to make change possible.
I was wondering if you could maybe speak a little bit about what are some of the biggest lessons learned in Pakistan that we can take to Afghanistan, particularly around the MNC edge topic?
It's a good question. And to first order, right, I figure we can never actually just take things directly out of one country and pluck it into another.
Yes.
What is clear, though, is if you think about trying to actually save women's lives and children's lives, the things that actually matter quite a lot are antenatal care and then that period around birth. And so what you want to ensure is like at an antenatal care that a woman is actually getting one, ideally 4 antenatal visits. At those visits, the provider is able to actually check for risk. So there's a thing of just making sure the ANCs are functional, right? We can give a list and say, okay, are these things present or not? And then actually the period of birth, the main thing we solve for is actually skilled birth attendants. So the idea is, right, rather than a traditional birth attendant or a birth at home, making sure that ideally the birth is happening in an institution or in some sort of facility. And if not, then at least with a trained midwife. And that's the main thing we're solving for. Now, the modality of how you do it might vary in Afghanistan. In Pakistan, we tried 2 things. One was there was like community midwives. We tried to get that to work, but actually realized that wasn't actually clicking. That actually wasn't resulting in that many deliveries. What actually did work a lot was actually making sure primary care facilities were open 24/7 and that the labor rooms are functional. And that actually was the unlock. That's what actually brought in tens of thousands of deliveries every month. And then we knew actually those were deliveries that were actually under the care of a midwife. And then later we solved for if that delivery was complicated, how to get it to a hospital. Yeah, which specific intervention, to be honest, like we need to actually work through what works in Afghanistan based on the network, but it's basically antenatal care needs to be sort of pick out risk, and then the point of delivery needs to be under the care of a midwife.
Yeah, there was one thing that you mentioned about the community midwives, right? Afghanistan and Pakistan, I think one thing that they have in common a lot, it's around like the health system is built around communities. So it's a community-based health system. I was wondering, how did you, is there any learning about how did we make the link between the communities and the health facilities? How were they connected? How did we make it happen in Pakistan?
So this was actually critical, and I think actually was maybe a bit underappreciated when we did the work. I mean, to be honest, the backbone, a lot of the work we did in Pakistan was the lady health worker cadre, which is basically, I mean, in Punjab, it was, I think, 40,000 women based in communities. They were not midwives, right? But they were trained community health workers who covered a range of needs in the community, mainly focused on women and children. What we got them to do is actually started to strengthen that link between that community health worker and the 24/7 birthing facility, where once a month, right, they would all assemble at the facility. They would actually say, okay, these are the women who are pregnant in my villages. Right. And I will be referring to them to come for either an antenatal care visit, but I'll be referring them over the coming month. And then as a woman got close, got into her 3rd trimester, to be able to say, this is her expected delivery date. So actually at the facility, you had a list to say, okay, this is roughly sort of all the women who will be delivering over this coming month. And then actually the facility would then follow up with that community health worker to say, what's the status, right? Like, is the woman still okay? Or what's happened? And so strengthening that link actually was quite fundamental. Now, there are other situations where you've got community midwives. I don't know if that's relevant in Afghanistan, but that's actually should be even easier to solve. It didn't work in Pakistan's context because, to be honest, actually the alternate to a community midwife was a traditional birth attendant. And women would always go to a traditional birth attendant over a community midwife, just in terms of trust within the community of who would you go to when you're in labor.
No, of course. That makes a lot of sense. I think there was one other thing you mentioned there, that there was also some sort of referral systems or some sort of like process or mechanism in place which ensure that deliveries which are complicated, which requires like maybe more advanced care, they were actually transported to the health facilities. I was wondering, like, how did that work? That's one. And second, how did we ensure that we not only focus on areas which are accessible, but also more remote communities which are far away from the health facilities?
Mm.
How did we make sure that we also there's a system in place that even those communities and people living far away from the health facilities,
Yeah.
they do have access to this type of healthcare?
So this is a good question, right? Because I think this is one which was like a reflection for me when I was project managing the work, was the importance of actually letting the government lead. From an access side, actually, we weren't thinking about this referral problem. We were thinking about, hey, let's get women into a 24/7 birthing facility, make sure they're, give birth under a trained midwife. Let's make sure that facility is functional. We weren't thinking about let's change the process or design of it. It was the government and the Secretary of Health who said, let's actually put in place a dedicated ambulance service that does these referrals. And actually the stretch he did, which actually, to be honest, my team was skeptical of, and the donors were skeptical of, was he said, we will outsource this to a third party to manage the entire network of ambulances. We ran with it, right? Like, yes, there was some hesitancy, but he wanted to do it. We ran with it. And Sherry, who you know really well, basically was responsible for making sure that system worked really well. And then what that allowed basically was a dedicated ambulance service focused on rural areas where if there was a complicated delivery at a basic health unit, the midwife could call, right? An ambulance would be deployed, pick up the woman, take her to a hospital where she could get a blood transfusion, see a doctor, et cetera, et cetera. That was one. Now, in terms of the rural areas, solved it in two ways. One is as we thought about the network of 24/7 basic health units, and this is actually where like GIS data has been very helpful, right? So we mapped population density. We tried to actually like design a network of facilities such that we had good coverage of the population. That was the first thing. We went from, I think, initially like 70 facilities to 200 to 250 to 700. The government subsequently took that to 1,000, 1,500, now I think 1,800. So there has been a push to say, like, let's broaden that network of facilities so you just get more and more of the population. But then the second mechanism was indeed this ambulance service, because once that ambulance service was there, it was also the entity that a woman in a community could call and say, I've just now gone into labor. I need to get to a basic health unit where I can deliver. And the ambulance would pick her up and take her to a health facility.
Oh, wow. Wonderful. So it seems that in this process, we definitely going to need a lot of midwives and also a lot of female health workers.
Yeah.
I was wondering if there was any learnings or there's a point where you thought that we don't have enough female health workers, or we do have female health workers, but they need trainings and things like that. And I was wondering if there was like any discussions around that and how do we fix for that?
So that's actually probably one where the challenge set in Pakistan and Afghanistan are different. Because in Pakistan's case, actually, the presence of midwives was not a problem. So you had enough trained midwives that actually come out of all the nursing colleges in Pakistan, and they actually had tailored a degree that it wasn't actually the full nursing degree. It was actually just focused on midwifery. That produced enough human resource for health. And the same is true actually in terms of the community health worker landscape. So for Pakistan, that wasn't the challenge. We faced that challenge in Pakistan when we got to doctors and specialists. So that was a problem there, but not for midwives and not for community health workers. So that's probably a unique thing that actually in Afghanistan you're going to have to sort of dig into.
Yeah, of course. The other thing which I always wonder about is that it's one thing to ensure that there's a skilled birth attendant during the deliveries, and also when there's complication, having the systems and processes in place to ensure that the mothers are transported to health facilities. How did we also ensure that the system is functional enough, meaning that when a mother is transported to the health facility, there's actually doctors available there. They have all the medical equipment that they need there, the medicines there. And also the same way, like if there's a skilled birth attendant in a remote village, how did we make sure that they have the right sort of medicine, equipment, and things like that to ensure a safe delivery?
The reason we were skeptical about going to that referral mechanism and everything was we were thinking actually much more, let's solve the level 1 problem, which is at a 24/7 birthing facility, how do you ensure that that labor room is functional, right? That there is actually staff present. If a woman shows up at 2 a.m, there's a security guard and there's a midwife there. How do you make sure that they have backup power, because power is an issue in Pakistan? How do you make sure there's backup power how do you make sure that, yes, there is a delivery table, there is a sterilizer, an autoclave, right? Like, how do you make sure all that equipment is there? And they had the basic medication that, if a woman starts to hemorrhage, they can actually stabilize the woman. And that's actually where all our focus was. So we started with, and this is actually like quite core to what Axis has actually taken to a number of countries, which is fixed site monitoring, where we make sure at last mile you have inspection, right? Random inspection of the facility. You see what's there, you identify the gaps, and you work with leadership to fill it. Now, the evolution that happened over the time that we were working was, we started with actually like what will be very familiar to you, right? Which is all the different indicators and trying to push them up. Yeah. With labor rooms in particular, we realized that that was insufficient. That actually, if any one item was missing from this list of critical items, really it wasn't safe for a woman to go there for birth. And so we raised this threshold, and actually this again was an idea that came from the department. We sort of tried to explain it, and then there was actually the project director of the MNCH team who said, okay, I got this. This is a knockdown criteria, and we will be rigorous on this. If any facility is missing any of these items, I will not consider it functional, right? And we will ding the sort of district health officer for not having made that facility functional, right? And that raised the bar quite substantially. And it's really actually only at that point where the facility is functional that we should feel comfortable, or we felt comfortable with actually having those referrals into the facility, right? Otherwise, maybe it's incrementally better than what's happening, but to be honest, like, you're not creating a safe environment for the woman to give birth.
No, absolutely. I think one other thing I'm noticing similarities is that for making such changes, it's not just one person or one team or one organization which is able to do all of it. It seems that there needs to be some sort of partnerships in place among different organizations and groups to deliver, like, collectively a successful program or project. I was wondering if there was anything around that.
No, I mean, sorry, yes, okay. Absolutely. ACUS's work, right, and I think we bring this to everything, is we're working with government, right? But government has a variety of partners. And what we're really trying to do is actually get government to have a clear vision, articulate that vision, and then align the partners to achieve that. So absolutely, UNICEF was playing an important role, WHO was playing an important role, UNFPA was playing an important role, and actually in specific smaller geographies, right, a particular district, there might be some NGO that was involved. And really it was just by creating focus around, hey, this is the thing that needs to be solved, that actually government was then able to align all those partner resources to actually realize this result. Otherwise, the issue, right, is that every partner is operating a little bit in a silo, right? And just saying, okay, this is my scope of work. This is what I'm trying to deliver. And you don't get the overall improvement of the health system. So the partner role was absolutely critical. And for us, it's actually enabling government to manage that network of resources and partners to achieve some larger vision.
That's wonderful. One other thing that I've been thinking about is that we know in contexts like us, a significant proportion of deliveries happens at homes. I was wondering if there was any learnings about how we can ensure to build trust between the communities and the people and with the health system, so that they come to the health facilities to receive treatment and services.
This is a really good question, Bahman, because that ultimately is like that's the thing we're reaching for fundamentally across all our work, right? Is actually raising the standard of government delivery in the health system such that actually citizens trust that they can go there and get quality of service, such that they don't feel they need to actually either forego treatment, which is one thing that happens, or feel that they actually need to spend a lot out of pocket, which honestly they can't afford to get treatment. So that's fundamentally what we're trying to do with all our work. At this point of delivery, it's actually really tricky because in Pakistan, it's similar. A lot of women in Punjab used to. Now I think actually the numbers have changed quite significantly. But at the time, a lot of women would also deliver at home with a traditional birth attendant. That process of building trust, I think there's a couple components to it. And it is quite difficult because, that woman will be going to a traditional birth attendant because everyone else in the community has also. That traditional birth attendant will be an older woman in the community who has delivered all the children in that village, right? And actually, in the cases where they may have had a complicated delivery, in Pakistan's context, it would actually be, oh, well, that's actually at God's will, right? That child didn't survive or that mother didn't survive. It is actually quite tricky and quite difficult to build that trust. I think the ingredients are actually probably 2 or 3-fold. One thing actually for better or worse, right, one thing that does matter is actually just the visual upkeep of a facility, right? A facility itself needs to be welcoming and sort of somewhat patient focused. So there needs to be clean, right? There needs to be actually a separate bathroom for women, especially during labor, right? There needs to be a bathroom near the labor room that a woman can get to without having to go through, say, another room, right?
Yeah.
So they need to have appropriate privacy in that delivery room. So a lot of elements that actually you might take for granted in other circumstances, but actually you do need to upgrade government facilities to provide that sort of nice environment that a patient would actually want to go to. That's one. Otherwise, it's so much easier to say, I will give birth in the comfort of my own home and privacy at my own home. So you actually need to do that, those sort of visual and physical upgrades to the facility. Second is actually the consistency of service needs to be there, such that actually if a woman does go for a delivery at a facility, they have a good experience, right? And that sort of comes back to the community, and it doesn't feel like it's such a abnormal thing to go to a facility for birth. So it's the consistency of then the services being provided is the second thing that I think was quite important. To be honest, I think is actually those were the two things, right? And then it actually takes time.
Yeah.
Like these things don't necessarily happen overnight. If there is a third thing, right, I think it was this point we touched on earlier, which is the importance of the community health worker. Because if you ask who actually has the confidence of a pregnant woman to be able to convince them that actually in this actually really important time where there's a lot of anxiety, that they should do something and actually should do something aside from deliver at home, it needs to be someone they trust. And the only person who can actually build that level of trust and confidence is the community health worker who's from their own community, who actually has been with them through the entire pregnancy and has been sort of, advising them of actually all the risks and making sure they actually go.
Wow. So now I know that Acasis as an organization, we rely heavily on data because the decision we make, it needs to be evidence-based. And I was wondering, we're not talking about one person or two person, right? We're talking about systemic change, making sure that the services are available for everyone. And in order to do that, we also need to understand that what the community actually needs, what are their perspective of what are their perception of the health system, would they think of it? Was there any data involved or was collected to basically see what is the level of people's awareness about these interventions and availability of these healthcare systems? What was their perception of the health system? Or do you think if it was not available back then, this is something that we should be thinking about to ensure that we're not just developing interventions and just going into the communities and launching them, but rather than also learning and understanding and taking feedback from the community?
Yeah. So yes, for sure, right? One thing we benefited from while doing the work in Punjab was we had very regular surveys to check outcomes. Right? So household surveys to actually check. For us, it was actually immunization outcomes, but we also were checking skilled birth attendance. So this was happening on a regular, every 6 months, right? So we had active feedback of data. You were asking about community perceptions, and man, that's actually where we relied on the network of partners, because actually once you start looking at the system, you realize people will be doing different NGOs, right? And different partners will be doing different little bits of the pie, right? Either on knowledge and awareness and perceptions, they'll be doing demand surveys, they'll be doing actually interventions to actually strengthen and bring women to facilities. And so it was really actually just analyzing a lot of the work that they did and saying, okay, which ones actually have the potential to scale, discussing them with government, figuring out which ones government would get behind, trying to pilot and scale, see if they actually take off. And if they do, then you sort of make it system wide. So I think there was regular data collection, but there was also just looking at what was there and actually figuring out how to actually get the government to just sort of, bring it system-wide.
I think for any good program, we also need to know if it was successful or not successful. And to do that, we need to have clear set of indicators to measure that. I was wondering, what was the measure of success for us in Pakistan for this particular project?
So there is a measure of success, right? Which is on these sort of 6 monthly surveys, we wanted to hit a certain target in terms of skilled birth attendance rate. For me, the thing that actually clicked that, okay, we're onto something and this is going well, was when one of the associates went into the field because actually there were suddenly facilities that were doing like 80 deliveries over the course of the month, right? So she went into the field to actually see what was going on, and she came back sort of with a smile on her face because baby had just been delivered at the facility. There was a nurse who had just delivered, and she explained actually like this is how she runs the system, right? She has these meetings with lady health workers every month, right? And she actually just walked through all the things that she was doing to make her health facility vibrant. It's like, okay, this is what's happening on ground, right? And actually, like, the associate on the team was able to see the output of that. So that was one where I think actually for the team as a whole, we felt suddenly like quite proud that you see very tangibly the impact. And this is actually why MNCH work is something I'm passionate about and would love Access to do more of, because unlike immunization where it's, yes, you're preventing a vaccine preventable disease at some point, at the point of birth, it's a critical sort of 24-hour period where the outcome of it is like this joyous moment of a mother with her child. And so that was one. The second was actually sort of, and this was probably in year 3 of the interventions, where the government had trusted that they could actually fund and actually make real upgrades. At some point, the secretary started sending me a bunch of photos on WhatsApp, which were coming from all over the province of upgrades that actually medical officers and midwives had made to their facilities. And I was looking at some of them and I was like, just sort of shocked looking at them. Like, is that actually how good our facilities look now, right? Because they actually look like a facility that I would be actually quite comfortable going into. And I was like, if we've gotten to that point, then actually something really fundamental has changed. So those were the two sort of points that clicked for me. The results showed up in the surveys also.
Yeah,
right?
of course.
But those were the things that for me clicked and it felt like, okay, yeah.
So it was interesting you talk about the associate when you were like one of those moments you thought that it clicked and the happiness felt there. How do you see the role of the people and their level of commitments to drive change as a successful measure here? Because from my previous experiences in Afghanistan and other places, I know that a successful health system which is providing quality services, or generally health system where they have a lot of motivated people at different levels of the system, at the front line of service delivery, mid-level management, upper level management, and even the policy level. I was wondering if there was any engagement at that levels, and how did you find that?
Yeah. There was, right? None of the work would have happened without them. As in the women who were actually showing up to do a night shift, right, or overnight shift, were dedicated midwives, right? And what was interesting is actually if you looked at, because we would check attendance, right, during an inspection visit, the rates, like the presence of midwives was always much higher than the doctors.
Wow.
Right? They were committed to their work. And I'm not to gloss over that, yes, there might have been some performance issues, but like they're the frontline workers who delivered everything. To be honest, when you actually engage them to understand what was wrong and what was broken, if you could actually engage them and genuinely get them to trust that, okay, this is going to come of something, they would give you a wealth of knowledge of what to fix, right? And so when we did focus groups with the midwives, they're the ones who sort of pointed out, oh, this is what I'm doing in my facility to actually result in 70 deliveries a month, right? And we learned from them. It's not like we cooked this up, right? We learned from them and then took it back to the Secretary of Health and took it to all the district health officers to say, hey, these are actually best practices that need to be cascaded throughout the system. And that's how you got the entire system to rise.
That was Faisal and Bahman on lessons from Punjab, Pakistan. The work in Pakistan shows what's possible when governments lead, partners align, and communities trust their health system. These lessons remind us that real progress is both systemic and deeply human, built by people brave enough to deliver change. If you enjoyed this conversation, subscribe for more episodes that explore how we're supporting the government to make health systems work better, one small detail at a time. This is an Access production in partnership with A+B Media.